Hello, and welcome to the Teen Driving and Community Mobility Educational Module created by myself, Celeste Johns. I have provided an additional handout for you to follow along and take notes to use as a reference tool. At any time during this presentation, you may pause the video for additional time to read and assess a slide. We'll begin by defining driving and community mobility. In the Occupational Therapy Practice Framework, 4th edition, driving and community mobility is categorized as an instrumental activity of daily living. It is defined as planning and moving around in the community using public or private transportation such as driving, walking, bicycling, or accessing and riding in buses, taxicabs, ride shares, or other transportation systems. Now we'll discuss typical teen characteristics. Not only are teens going through many physiological changes as they mature, like changes in voice and body due to hormonal adjustments, they are also going through cognitive changes like developing more advanced reasoning skills and ability to use abstract thinking. However, did you know that teens ages 12 to 16 years old have less myelination in the frontal cortex compared to young adults ages 20 to 23? You may reference the bottom left-hand corner for a refresher on myelination. As we discussed in the previous slide, many of these changes are occurring in the frontal cortex. The frontal cortex is involved in many high-level cognitive processes in executive functioning, such as memory, emotions, problem solving, impulse control, motor function, and social interaction. Teens are 3 times more likely to be involved in a motor vehicle accident. In fact, in 2019, almost 2,400 teens were killed in a motor vehicle accident. That's 17 deaths a day every day for the entire year. So, there are several factors that increase the risk of car crashes among typical teens, like increased emotional intensity, which is experiencing extreme highs and lows in response to varying situations, and increased want to explore social opportunities, increasing their exposure to risk and risk-taking behavior. In 2019, the CDC noted various risk factors in relation to teen fatalities and motor vehicle accidents. One of the most common reasons that put teens at a higher risk for accidents is inexperience. They are more likely to underestimate dangerous situations. 40% of 2019 fatalities, teens 13 to 19 years old, occurred between 9 p.m. and 6 a.m. More than half of those fatalities occurred on a Friday, Saturday, or Sunday. The next common reason for teen fatalities in the car were due to not wearing a seatbelt. This accounted for approximately 48% of deaths. There are many forms of distracted driving, but the most commonly known form is texting while driving. 39% of high school students admit to texting and driving. New and young drivers also tend to speed more frequently. In fact, of the 2,400 teen driving fatalities in 2019, 31% of males and 17% of females were speeding. And although it is illegal to drink and drive, 24% of the 2019 fatalities had been drinking, and 15% of those had a blood alcohol content of more than 0.08%. This occurred more frequently in males than in females. Finally, drug and substance use also played factors in increasing the risk of accidents. For example, marijuana negatively impacts judgment, motor coordination, decision-making, and reaction time, which are all significantly important skills for driving. This pyramid depicts Michon's 1979 model of driver behavior. It is hierarchically structured from bottom to top. The lowest part of the pyramid, operational tasks, is made up of the most basic controls of the vehicle. Examples are steering, utilizing the brake and gas pedals, using turn signals, wipes, and cruise control. Moving up the pyramid, the tasks become more difficult. Tactical tasks involve motor planning and reactions while driving, like slowing down due to an obstacle or applying the brakes when coming to a red light. Finally, the most difficult of functions falls within the top of the pyramid in strategic tasks. This is where the decision-making process occurs, like navigating to a destination or determining an alternate route due to accidents or other obstacles. Let's review some of the information we have discussed this far. What skills do typical teens struggle with due to less myelination in the frontal cortex as compared to adults? Select all that apply. The answer is memory, emotions, problem solving, social interaction, impulse control, and motor function. Here is the second knowledge check. This activity is a drag and drop, so you will select an answer and drag it to the appropriate box. We will now begin to discuss community mobility. The first form of community mobility is private transportation. Forms of this include walking, driving an automobile, and riding a bike. The leading cause of death and disability in adolescents remains to be motor vehicle accidents. Another form of community mobility is public transportation like bus, train, subway, or ride shares. These can be particularly difficult to maneuver due to the complexity of the systems, having to do transfers, navigating schedules, and an increase in cognitive load on the individual. We will now move forward to discuss performance skills important to driving in community mobility. These can be found in the OTPF 4th edition. This list is not exhaustive. There are other motor, process, and social skills required for driving and community mobility. Essential motor skill examples are positioning self an appropriate distance from the steering wheel, gripping the handrail to support oneself while boarding a bus, and calibrating by modulating force applied to the gas pedal while traveling uphill. Next, we'll go over some important process skills for driving in community mobility. Some examples are attending to the road while driving, inquiring the name of the next bus stop on a bus route to ensure that the client departs at the correct location, and sequencing by utilizing the turn signal before performing a lane change. Social skills are also very important in driving in community mobility. A client may need to gesticulate to another driver to communicate during a four-way stop. When verbally giving another person directions, the client provides an answer without including unnecessary details or speaking for an excessively long period. Finally, the client might empathize with an individual who missed their bus stop and becomes frustrated. Moving forward to client factors, we will discuss mental, sensory, and neuromusculoskeletal body functions. First, mental. The first example is attention. Teens and young adults who have difficulty with sustained attention, divided attention, or selective attention may have absent or delayed reactions to driving environments. They may be unable to sustain attention on quiet roadways, have difficulty shifting attention from one stimulus to the next, or be challenged by distractors in the environment such as pedestrians on the sidewalk or passengers in the car. Next, sensory. An example would be for vision acuity. Teens and young adults with visual acuity impairments may have difficulty reading signs and seeing brake lights or traffic lights. Next, for neuromusculoskeletal, joint mobility. Teen and young adults with limited range of motion in their spine or upper extremities or lower extremities may have difficulty operating a standard vehicle equipment. For example, a teen with limited spine rotation may be unable to use side mirrors or turn to check the blind spot during a lane change. A teen with limited shoulder flexion may have difficulty reaching the steering wheel. A teen with limited ankle inversion and eversion may have difficulty effectively moving between the pedals for adequate brake reaction. There are many factors that influence whether driving and community mobility is addressed with a teen or not. These factors can either support this goal or act as a barrier. There are many examples because each individual is unique, but here are a few to start. If both the family and the client have high motivation and a positive support system, it is more likely that driving and community mobility may be addressed and become a realistic goal. Conversely, a lack of motivation makes the goal less feasible. Next, resources like adequate time and funding to put towards training, having a vehicle to practice safe driving skills, And even having an IEP or 504 plan in place has potential to enable driving and community mobility. If individuals don't have access to services such as driver rehab, driving school, or occupational therapy, addressing driving and community mobility may be more difficult. The location in which a teen lives may contribute to access to such services due to proximity. Additionally, living in an area with high traffic, increasing driving setting complexity, could make practicing or engaging in driving more difficult than someone who lives in an area with low traffic and low speeds. Finally, a full understanding of awareness of risks, as well as what accommodations are needed, can further support addressing driving and community mobility, whereas low awareness could potentially act as a barrier. Moving forward into disabilities and driving and community mobility, typical teen characteristics and obstacles posed by disability equals a required increased support for driving and community mobility due to increased complexity. First and foremost, research is limited regarding teens with disabilities and driving. However, there are a couple of common diagnoses that may seek rehabilitation and training for driving and community mobility. These disabilities consist of ADHD, anxiety, ASD, visual impairments, cerebral palsy, spina bifida, and many others, including dual diagnoses. We'll begin with ADHD and anxiety as they can present with similar challenges. These individuals may have decreased performance due to challenges with executive functioning like selective attention, impulse control and judgment, visual spatial skills, information processing, reaction time, and difficulty adjusting to new environments. A few examples are these individuals may miss important traffic signs while driving. They may have difficulty with lane maintenance and problem solving a new route if the familiar route is under construction. In fact, teens with ADHD are 36% more likely to be involved in a car accident due to increased risk-taking behaviors. Individuals with ASD may have decreased performance due to challenges with sensory processing, spatial awareness, attention, like divided and sustained, social skills, executive functioning processes, tolerating unpredictable environments, and even hand-eye coordination. A few examples are the person may view someone walking on the sidewalk and the car in front of them braking as equally important, thus having difficulty prioritizing which task should be attended to in the situation. Another is an individual with autism may be unaware that a tailgating vehicle may pass them soon. Or they may have difficulty with navigational directions due to interpreting verbal commands literally. These challenges may contribute to the fact that there are only 1 in 3 teens with ASD obtain a license by 21 years of age. Additionally, those with dual diagnoses of ADHD and ASD are at an even higher risk of crashing. Next, we will discuss individuals with cerebral palsy and spina bifida because they may present with similar challenges. They may experience decreased performance due to challenges with executive functioning, memory, eye-hand coordination, judgment, strength and balance, and visual functions such as acuity, color, field of vision, and perception. Examples include individuals with CP or SB who may lose some function in their lower extremities, affecting their ability to drive a standard vehicle, thus requiring them to modify their vehicle with driving controls. They may also have difficulty performing lane changes, navigating, noticing traffic signs in visually cluttered locations, and they may need assistance in determining an accessible route. Did you know that about 80% of our sensory input is processed through our eyes? The last condition we will discuss is visual impairment. There are many diagnoses within this category. Oftentimes, these individuals may have decreased performance due to challenges with acuity, field of vision, eye dominance, figure ground, contrast sensitivity, tracking, and nystagmus. So this is an extensive list of examples, but a couple of examples include difficulty reading signs during the day or night while stationary or moving, and having to use a telescopic bioptic device to read traffic signs if legally blind, while also attending to motion and colors in the peripheral field. So what is the role of OT in driving and community mobility? The practitioner can provide their expertise and input on determining appropriate mode of transportation, transporting in vehicles safely, determining the degree of independence the individual might have in community mobility, determining if the individual may qualify for paratransit services, utilizing power equipment, and providing community resources to the family. An occupational therapist can assist the young driver population by addressing pre-driving skills to promote independence, like ability to cross streets, manage social interactions, manage time and money, handle an emergency situation, manage impulse control, stress reduction, and sensory input regulation. Furthermore, adolescents and young adults depend on transportation to independently access employment, gain housing, attend school, social, and recreational events. This makes driving and community mobility an occupation enabler, meaning it allows for participation in other meaningful occupations like work, education, and social activities. For teens, the inability to drive or maintain a sense of independence can cause low self-esteem, and decreased confidence can make individuals feel more likely to keep to themselves. OTs have the ability to supply individuals with the opportunity to engage in community mobility to increase independence and autonomy, thus increasing self-perception. Often, practitioners may not address driving and community mobility due to various reasons. So, why are they hesitant to address it? Commonly, generalist practitioners may lack confidence and competence due to inadequate training from their graduated OT program or continuing education. However, AOTA has published a model called the OT Drive to address this issue. Next, therapists or facilities may fear liability issues that may come with driving and not want to pay for additional professional liability insurance. Furthermore, some practitioners already feel that they have limited time and funds to address other aspects of OT and don't have a professional mentor to assist them with decision-making related to driving and community mobility. Next, students may not qualify for school services, or insurance may not cover therapeutic assessment and intervention for driving and community mobility. In the school systems, the therapist is unable to discuss an area of concern, like driving, if the school does not provide driver's education and because the school may have to pay for services they do not already provide. Also, the DMV does not provide adequate public safety information regarding teen driving with disabilities or learning differences, and few pediatricians discuss concerns for driving with parents. Additionally, there are no current disability standards in the national guidelines for driver's education, so driver schools do not have an existing framework to best address medical driving needs. The occupational therapy domain and process begins with theory, continues with evaluation, which leads to intervention and eventually outcome. Practitioners use models and theories of occupation to guide their decision-making in the occupational therapy domain and process as they evaluate, provide intervention, and meet desired outcomes. The PEOP theory is a transactional model between the person, their environment, and the occupation to create the occupational performance. This image depicts the application of the PEOP theory in driving and community mobility. Potential person factor examples located here are stress, attention, problem solving, coordination, and many others. Examples of environment factors located on this side are personal relationships, state laws, family values and beliefs, and more. We have another knowledge check to review the theory we just discussed. Which of the following are person factors in the PEOP model? The answer is stress, coordination, motivation, and strength. The second question regarding the PEOP model is which of the following are environment factors in the PEOP model? The answer is assistive technology, relationships, road condition, and policy. Now that we've established a theory, we will move forward to the evaluation. The generalist evaluation takes place in a clinic or residence. An occupational profile is obtained to identify important factors like supports and barriers in the client's life. And lastly, the OT will utilize evidence-based assessment tools to examine client factors and performance skills. Assessments essential to driving and community mobility include developing an occupational profile regarding the client's medical history, medications, client's environmental context, performance skills, and additional relevant information. Vision assessments can examine acuity, depth perception, color perception, tracking, and visual motor skills. Cognitive assessments will look at memory and executive functioning skills. Motor skill assessments examine bilateral coordination, eye-hand coordination, balance, or crossing midline. Sensory assessments will look at an individual's response to sensory input. And finally, an IADL assessment will provide information regarding the client's independence and additional IADLs. After the evaluation is complete, the practitioner will proceed to intervention. In the OTPF4, there are various types of interventions. We will cover a few of the ones on this slide. The first type is occupation. An example would be participating in community mobility, so walking to school, using public transportation, or a community outing. The next we'll talk about is activities. An example for this intervention is engaging in vehicle transfers, navigating thresholds, planning a route for public transportation, increasing performance skills, and observing others. Assistive technology and environmental modifications can be downloading smart device applications to support performance or referral to adaptive driving program. Examples of apps are Drive Focus and Auto Coach. Other types of interventions are wheeled mobility, self-regulation, education and training, and advocacy and self-advocacy. Appropriate outcomes can be tied back into the original theory guiding practice. In this case, PEOP outcomes are an increase in performance, participation, and well-being in driving and/or community mobility. I will now introduce the Certified Driving Rehabilitation Specialist, or CDRS. These individuals are often allied health professionals like OTs or driving instructors whom have completed additional training and have taken and passed a formal certification exam by ADED, the Association for Driver Rehabilitation Specialists. They can provide comprehensive evaluations behind the wheel if deemed appropriate. They can determine driver readiness and, if it is safe, provide the client with training strategies, compensatory techniques, and adaptive equipment. These specialists can provide resources and counseling if driving is not appropriate. CDRSs assess reaction time, emotional regulation, sensory perception, cognition, motor, and practical skills, communication or social skills, comprehension of traffic rules, and additional on-road driving skills. They are highly skilled and retain a narrower focus on safest form of mobility, vehicle assessment and intervention, adaptive equipment, and recommendations pertaining to vehicle modifications. To begin the process, the CDRS will conduct an evaluation. The first part of the evaluation is a driver fitness assessment, typically conducted in a clinic. Here, the CDRS will assess things like vision, brake reaction time, and road judgment. If the client meets state requirements and is deemed safe by the CDRS, a behind-the-wheel assessment will be conducted. The vehicle used for this typically has instructor brakes and mirrors, as well as adaptive equipment if necessary. During this part of the evaluation, the CDRS will assess driving-specific tasks like setup and position, vehicle position and speed, numerous real-world driving scenarios, awareness of others, essential maneuvers, tactical and strategic decision-making. Following the evaluation, if the client is deemed appropriate for training, the CDRS will begin implementing therapeutic interventions into the sessions. These consist of, but are not limited to, visual search and scanning, timing and sequencing of maneuvers, orientation and positioning, decision-making, strategic planning, adaptive equipment and restrictions, and extended breaks. This slide provides a comparison table between the OT generalist and CDRS or specialist. This table helps identify the similarities and differences discussed in previous slides. This slide provides additional resources. You can explore vehicle modification, AOTA's driving and community mobility webpage, CDRS versus DRS by ADED, and Drive at Home for Parents by National Safety Council to explore on your own. Here is a case study to practice what we have learned today. Utilize the skills and knowledge you have learned in this module to work through the OT domain and process. There is an additional Word document with this case study example for you to practice on your own. Here is the list of references provided.